Welcome to Webisode 4 on split dosing. I am Eric Morse, an addiction psychiatrist who has over 18 years of experience working in opioid treatment programs. Split dosing is done for a minority of patients who are rapid metabolizers. The concern for split dosing in OTPs is primarily the diversion of the second dose, especially in patients who are still actively using. For this reason, medical necessity must be documented clinically in the medical provider's notes. In serum and peak trough levels performed accurately, and in the CSAT extranet exception request. An exception request must be submitted and approved prior to splitting a patient's dose of methadone or buprenorphine. For methadone, all the data that you would need for a special take-home should be included, plus the nanogram per milliliter of their peak and trough levels. Also, medical reasons for increased metabolism, like pregnancy or being on other medications that might induce the metabolism of methadone, should be included. The half-life of methadone is variable based on liver metabolism. It typically ranges from 24 to 55 hours. Remember that the half-life is the time that it takes for the medication to drop 50% in serum levels. So if it takes 20 hours for methadone to drop from the peak of, say, 800 nanograms per milliliter to a trough of 400 nanograms per milliliter, then that would put the patient right on the cusp of being a rapid metabolizer. Typically, it's required for patients to have a peak to trough ratio of greater than 2:1, or a half-life of less than 24 hours, to qualify for split dosing. Before considering split dosing, you should meet with the patient and think about why you cannot simply increase the AM dose. Sedation or nodding or other signs of methadone toxicity at the peak, 3 to 4 hours after the dose, would be the main reason. Observing the patient at the peak would be ideal, but not always possible. Getting collateral information from family, friends, coworkers would be helpful to document. The lab results of the peak and trough levels are also required and helpful. Other considerations when evaluating the need of split dosing are the use of other drugs, stimulants, like amphetamines, cocaine, or methamphetamines can increase the metabolism of methadone and make a patient who is a normal metabolizer appear to be rapid. Other medications like Dilantin can do the same. So before contemplating getting a peak and a trough, drug-drug interactions should be reviewed. The medical, mental, and social stability using the 8-point take-home criteria discussed in Webisode 2 must be considered before deciding to offer a split dose. It would make sense that split dosing should be 50%, 12 hours apart to maintain the most consistent blood level 24/7, to reduce the risk of diversion, making the second dose of the day lower than the first dose should be considered, especially if the patient is at higher risk of diversion. The half-life of buprenorphine, because it's sublingual and bypasses first-pass metabolism in the liver, is a lot less variable. The half-life is 37 hours. Splitting the dose of buprenorphine should not be required in the OTP setting. In the OBOT setting, buprenorphine may be split for pain benefits or to reduce side effects. In OTPs, especially with methadone, we make clear lines that we are not treating pain, that we are only using methadone or buprenorphine to treat opioid use disorder. Since there are no available commercial tests yet of serum blood levels of buprenorphine, the medical director must use his or her best medical judgment, weighing the benefits versus the possibility of diversion of the second split dose. The exception request approval may come with an expiration date. The need for split dosing should be continually evaluated. Is the patient doing better since the split dose? Has the patient who's been receiving split doses remained stable for take-homes? Has the patient's medical conditions, medications, or stimulant use changed? Converting the second split dose over to the first dose while looking for signs of symptoms of methadone toxicity at the peak may be required to help the patient get stable again and reduce the risk of diversion. Considering an afternoon callback to evaluate diversion may or may not be possible. These factors should be discussed in the treatment team. If you have further questions, please feel free to contact your state opioid treatment authority. Thank you so much for watching, and keep up the good work.